My name is Kate Lapham, and I am the lead for USAID's Education in Crisis and Conflict Network. We are so grateful for your membership and your engagement by joining us here today. I want to acknowledge the various organizations and country contexts that are represented here today by your attendance. It is wonderful to see people from World Vision, from USAID, coming in from Africa, from Latin America. We really appreciate your attendance, and I hope that you will continue to introduce yourselves to each other in the chat. So the objectives for our webinar today are to learn more about best practices and evidence that support recovery from COVID-19 related disruptions in education, to be able to network with our expert panelists and fellow ECCN members, and also to explore routes for future collaboration among fellow members and hopefully be inspired to continue engaging with the network as a whole around these shared topical priorities. The agenda for today's webinar includes presentations from Giulia di Filippantonio from the International Rescue Committee, followed by a brief question and answer session, a presentation from Daniel Tobón from Welbin, followed also by a brief Q&A, small group discussions for about 15 minutes, and closing remarks. I will now share some norms for our time together. Live English closed captioning is available for those who want it by selecting the CC icon at the bottom of the screen. As a reminder, please ensure that you are either in the English, French, or Spanish audio channel by clicking on the world icon at the bottom of your screen. Please do not use the original audio channel even if you are listening in English. Please mute your microphone and turn off your video camera when you are not speaking. You may post on-topic comments in the chat whenever you would like. And in case you missed it just a moment ago, we are recording so that those who cannot attend can access the information afterwards. After presentations from our speakers, we will have about 15 minutes for breakout rooms. This is your chance to connect with the ECCN network members and exchange best practices. Please write French or Spanish next to your name using the rename function in the participant list if you would prefer to be in a French-speaking or a Spanish-speaking breakout room. If you need technical support at any time during the webinar, please send a private message on Zoom to USAID ECCN using the chat function at the bottom of the screen. The USAID Crisis and Conflict Network is part of the USAID Leading Through Learning global platform, which includes two other global learning networks, the Higher Education Learning Network, or HELEN, and the Global Reading Network, or GRN, as well as regional chapters in Latin America and the Caribbean and Africa. We hope that in addition to staying tuned to ECCN, you will be interested in collaboration across the platform. If you are not already a member, you can register now using the QR code to receive invites to future events for all of the learning networks and chapters, as well as other opportunities to convene with fellow ECCN members and engage. I am really pleased to introduce some key leaders for ECCN who have helped make today's event possible, members of the ECCN steering group. This group came together for the first time in March of 2022, and they have already demonstrated wonderful collaboration and elevation of cross-organizational priorities in the realm of education in crisis and conflict that ECCN can facilitate. The focus of our conversation today follows from the steering group's identification of topical priorities for us to tackle as a network, which includes safety and well-being. Welcome to those steering group members who are joining us, and thank you for all you do to support inclusive quality education in crisis and conflict. Before I pass the mic to Giulia to introduce herself and the EAGER project, I want to note that the video presentations that you are about to see are pre-recorded. These videos will be available on the LTLGP YouTube channel and the ECCN LinkedIn page, where we can all continue the discussion. Giulia, please.
Hello, everyone. My name is Giulia di Filippantonio, and I am the senior team lead for the EAGER project with the IRC in Sierra Leone. For the past 4 years, I've worked very closely with partners and education sectors in Sierra Leone to provide leadership in coordinating and implementing the EAGER project, and that included navigating the various barriers that girls face in Sierra Leone and the additional risks and impacts that the pandemic brought about in the country, especially for girls. We know that girls are at the intersection of many barriers, and in times of crisis, they are often further isolated and marginalized, with severe impact on their mental and psychosocial well-being. So we have seen this firsthand in EAGER during the pandemic. And so it was a priority for us to find the best possible way to help the girls where they are to go through these difficult times. So I will speak a little bit about this in the presentation. And as you listen through, feel free to drop any question you may have in the Q&A space, which you can access through the QR code on the screen. Thank you all. Hello, my name is Giulia di Filippantonio. I am the senior team lead for the Every Adolescent Girl Empowered and Resilient project in Sierra Leone with the International Rescue Committee. In this video, I will talk about how the EAGER project in Sierra Leone took action to support adolescent girls' psychosocial well-being. EAGER is a project implemented in Sierra Leone through a partnership between Restless Development, Concern Worldwide, BBC Media Action, and the IRC. As a consortium, we reached over 27,000 girls ages 13-17 across 10 districts through 2 cohorts over a period of 4 years. All girls enrolled in EAGER were out of school and among the most educationally, socially, and economically marginalized girls in their communities. Many girls lived in hard-to-reach areas. The project sought to strengthen girls' sense of power inside themselves, power to act, and power with others. We created girls-only safe spaces where they can learn new skills, build their confidence, and strengthen their social networks. We created tailored learning materials reflecting the needs and daily realities of these girls, including curricula in life skills, literacy and numeracy, and financial literacy. We recruited and trained facilitators and female mentors within each community to work with the girls, and we work with community leaders to strengthen their awareness of the challenges that girls face on a daily basis. We learned from the EAGER baseline assessment that more than 90% of girls had never attended school. Nearly half were food insecure and impoverished. 44.1% of girls were married, and 57.5% had 1 or more children. 14.6% of girls were living with 1 or more disabilities. Of those with a disability, 60% qualified in whole or in part due to their daily experiences of anxiety or depression. Many girls demonstrated hostile attribution bias and moderate levels of emotion dysregulation, confirming the need to integrate a strong emphasis on girls' psychosocial well-being across all aspects of the project. When COVID-19 hit Sierra Leone in June 2020, EAGER carried out a survey with over 500 enrolled girls. 82% reported an increase in stress and anxiety. This was not surprising, given increased household economic stresses and violence against girls. So we immediately began adapting our materials so we could best support girls' psychosocial well-being through this period. We coached mentors to be kind, supportive, and inclusive of all girls, both while facilitating as well as outside of sessions. We also encouraged girls to create a safe space for each other and emphasized confidentiality and what it means to be a good friend to each other. We also incorporated storytelling into sessions. Girls met a fictional character named Bintu and saw her learn, grow, and use her skills and knowledge to overcome familiar challenges. This included writing stories that normalized stress and anxiety, as well as sensitive topics like menstruation, sex, and pregnancy, so girls were better equipped to stay safe. Sessions also responded to girls' immediate experiences during COVID-19. Bintu helped us approach topics in a way that made it easier for mentors and girls to discuss them. Bintu and her friends highlighted risks girls might face, including early marriage, intimate partner violence, and sexual exploitation. They role model talking to trusted friends and adults, making safety plans, and using assertive communication to say no when they felt unsafe. Bintu also assured her friends that they were never to blame for violence they experienced. The weekly Eager Radio program also presented relevant issues through the eyes of girls, and we as well launched a series of 6 community dialogues with influential persons in the community and caregivers. We will look more closely now at 2 of the components that the Eager project introduced to support girls' psychosocial well-being during COVID-19. These are storytelling and stress management practices. This is one of the Bintu stories from the life skills sessions. Bintu, like the girls, is now facing COVID-19, most commonly called coronavirus in Sierra Leone. The stories are best told by a storyteller, so let's listen.
Bintu did everything she could to stay safe from the new coronavirus, but she is still worried. She worried that her family and friends will get sick. She worried about having enough money for food. The more she worried, the more stress she felt in her body. Her belly felt tense, and she did not feel like eating. She had pain in her shoulders and neck. She was not sleeping well and felt tired in the day. Sometimes she wanted to cry, but she stopped herself because she thought she needed to be strong for everyone else.
Eager officers who work in the communities coaching mentors to lead the life skills program told us some girls have asked how far Bintu lives from their community and if she's going to come to their graduation. From Bintu, they are learning how to see solutions and talk about things to cope with their own anxiety and sadness. We believe storytelling works because it taps into a traditional communication method. These girls are not used to being in school, but they are eager to tune into stories. Mentors are encouraged to first read and understand the story. They then translate and practice telling the story in their own words. This way, they can bring it to life. The program also introduced stress management practices, which focuses on deep breathing to calm the central nervous system. This approach was very new for the girls, mentors, and officers. We wrote the scripts using simple language and repetition and created audio recordings in Creole, which is widely spoken across Sierra Leone. Here is a short clip so you can hear what it sounds like.
Today, we can learn how to blow inside we belly. We that go help we for feel easy when we feel stress. Stress can make we body tense and can make we blow fast one. Anytime where we blow fast, this can only make we blow inside and out of we chest, and the breeze not reach inside we belly.
We asked the 60 officers for feedback on these practices, and the majority of responses were positive and encouraging. I myself have seen how girls use these practices even outside a safe space. Using audio works because it is something new and has captured girls' attention. As we prepared to scale up to reach more girls, this feedback has supported our learning and guided us to make further evidence-based adoptions. Evidence from EAGER tells us that by the onset of puberty, many girls in the hardest to reach areas experience increased isolation, confining responsibilities, disproportionate burdens, gender-based violence, and harmful traditional practices that altogether severely affect their psychosocial well-being and social-emotional skills. In times of crisis, strengthening girls' resilience requires a strong focus on their psychosocial well-being. Contextualized strategies, as adopted by EAGER, can be effective in reinforcing personal coping skills by normalizing difficult feelings, reinforcing girl solidarity, and shifting blame away from girls, fostering a more supportive, healthier environment for girls.
Thank you so much, Giulia. So let's go to the Slido and see what questions we have. Please feel free also to post your questions in the chat. So I think our first two questions are elaborating on how the project's mentors and officers are trained and how COVID-19 related closures affected the safe spaces. Giulia, do you want to take a few minutes to respond to these questions while people put more in the chat or on the Slido?
Sure, of course. In relation to the first question, I think the very first important element to consider is that our mentors had very low literacy skills, and they were coming as the girls from very remote areas of Sierra Leone. This meant that their education level was lower than anticipated and lower than it would have been ideal to be able to really support and coach the girls as we hoped. So after we learned that through our baseline evaluation, we made sure to tailor the training and continuous professional development model for the mentors to be able to cater for their needs. This meant simplifying the content and breaking it down into small bites as opposed to delivering large trainings or large activities with them. So we created tailored training modules as well as small learning clusters where mentors from a small geographical cluster, usually 5 communities, would come together and under the facilitation of an officer would go over the life skill sessions, would go over the stress management practices together, and would practice as a group. They would be able to share experiences, share learnings, and really through peer learning, build their skills and build their capacities. They used to meet every month. And so this has supported an ongoing learning process, an ongoing capacity building process for the mentors. There was another question around how COVID-19 affected the safe spaces closure. That's a really good question. Indeed, for the first 4 to 5 months of the project, we had to pause implementation, first of all, to comply with the regulations that were put in place by the government of Sierra Leone to reduce the spread of the virus. But at the same time, we used that time to adapt the program, to develop the stress management practices, to shift, to repivot the program, to really prioritize psychosocial well-being. And so during those 4 to 5 months, the safe spaces were not operating. But as soon as we adopted the program, developed a tailored module to really prioritize what the needs of the girls were during the pandemic, we resumed implementation in the safe spaces with the support of the government of Sierra Leone, of the Ministry of Education and Ministry of Gender and Children's Affairs. And we were able to restart sessions in the safe spaces, even in times where the schools had not reopened yet. So having a community-based model with community-based safe spaces that were validated by the girls themselves was really essential and critical for us to be able to continue to support the girls who otherwise would have been further marginalized during the times of COVID-19.
Thanks so much, Giulia. Could you talk a little bit more about girls and how this program strengthened their individual resilience?
Sure. I think that the whole program design is centered about equipping the girls with the skills, the information, the knowledge, and the confidence to really step into their power. So power to act with others, power to take decisions for themselves, power to take collective actions within their communities. And so really building on the socio-ecological model, looking at the different layers and the different dimensions of the girls' lives, starting from the personal, their personal needs, moving on to their relationships within the households and within the community and within society at large. And really looking at the barriers that they face at each level, then defining strategies that address the barriers at each of this level. It was an effective approach. Evidence tells us that the approach has worked well to support girls stepping into that power. So by equipping girls with those skills, by equipping girls with that confidence, through our community engagement approach, as mentioned in the presentation earlier, part of the program design was about engaging communities to really understand the barriers that the girls face, but also take action to address those challenges. And so through transformative community discussions, as well as social behavioral change communication with our partner, BBC Media Action, we implemented a multi-tiered approach to engage with community, raise their awareness, increase their understanding, and shift norms. This has helped creating a safer and more supporting environment for the girls to exercise the power that they have gained through the project.
That's great. So 2 more questions that are hot in the Slido. One was how you managed the husbands of the girls, whether you allowed them to participate in the project. And then also, how did you identify whom to engage from the community, and what was that impact at community level?
Very, very good questions. In relation to how we engage the husbands, initially, the project envisaged to engage young men, older boys in the communities in a series of life skills sessions. However, because of the impact of COVID-19 on our project resources and timelines, we were not able to do that. So we had to think creatively about other ways that we could engage men in the communities with limited resources and limited time. So we did that through specifically targeting young men or older boys in the communities. Most of them were husbands of the girls enrolled in the program in the community dialogue sessions. These sessions were structured so that a listening session with the girls would take place first every month. Action points and talking points, concerns that the girls raised during the sessions would then be brought into the community dialogues with the men in the community. We had 2 series of discussions, one series with caregivers, the other series with influential persons in the communities, which included men and husbands of the girls. So by attending these community discussions over a period of 8 months, men and husbands of the girls were engaged in thinking critically about the barriers that the girls face and the actions that they can take to act as allies of the girls. This was one of the strategies. They were also engaged from the get-go through sensitization and making sure they were aware of what the project was doing. They were also targeted through our radio shows. The primary audience of the show was indeed the environment around the girls, so the households and the community. There was another question in relation to how we identified community members who attended this activity, this component of the program. We made sure that caregivers or parents of the girls enrolled in the program would be identified and would be engaged in the community dialogue sessions. At the same time, we engage community leaders, mommy queens, which is a Creole expression to identify female leaders or trusted women in the communities to make sure that the group would have women's attendance and representations and would be more balanced, and also create an opportunity for the women in the communities to speak up. And so this is how we identify the participants into those discussions, but I can provide more details later on in the breakout groups as well. Thank you.
Thanks so much, Giulia. I want to take just a couple of questions from the chat and then offer participants who would like to voice their questions the opportunity to do that. So there's a question about what other special strategies can be used to reinforce male involvement and manage attitudes. And then also a question about the age range for the content of the program.
In terms of the age range, we targeted girls between 13 and 17 years old. However, some girls were waitlisted during the first cohort of the program. And so they ended up being 19 years old when we enrolled them in the second cohort. So overall, we had girls between 13 and 19 years old, or aged to be 19 years old, by the time the program ended. But that's what our target group really was, 13, 17. And then in relation to other strategies to engage males' involvement and transform attitudes at community level, I think a great focus of the project was about shared responsibility and shared accountability and promote collective action. So that the curriculum that was developed, that was created for these community discussions, was aligned with the life skills curriculum that the girls were learning, and it was aligned with the social behavioral change communication content, the radio content that was also being produced. So there were three different, if you like, streams that were being implemented concurrently and that were designed in an integrated fashion to make sure they would support each other. So while the girls were attending the life skills sessions, the community was attending the community dialogues with an element of accountability towards the girls, because the action points from the listening sessions with the girls would be brought into the community discussion. So there was an element of responsibility at the community level to listen to what the girls had brought up previously, and then an element of accountability to make sure that they would set action points at the end of each discussion to address the concerns that the girls had raised. The same content, the content that was addressed, that was covered in the community discussions and in the life skills sessions, was also reflected in the radio component of the program. And so by developing a very holistic model, with very integrated, well-integrated components, we were able to make sure that every component would reinforce each other by, at the same time, targeting multiple stakeholders at the community level. I hope that answered the question for now.
Thanks so much, Giulia. Is there anyone who would like to come off mute and ask a question? Please use the raise hand function. Okay, I'm not seeing any raised hands, so we're all shy, but I can see in the Slido questions about um, some of the coping strategies that were suggested by mentors and girls, and also questions about how you've been able to identify girls with different types of emotional distress. So perhaps we can finish up the Q&A with those two.
Sure. I guess in terms of how we were able to identify girls with emotional distress, as part of the baseline assessments, we did carry out an assessment to make sure we could identify girls with disabilities. And as mentioned in the presentation earlier, we were quite, I guess, surprised to see how many of those girls would qualify as having a disability, because they reported anxiety, they reported stress, they reported signs of emotional dysregulation. So from the get-go, at the baseline assessment point, we were able to identify girls who had these additional needs. And then during the COVID-19 pandemic, at the start of the pandemic, we carried out surveys and focus group discussions with the girls and with the mentors to understand how the pandemic was affecting us and was affecting the girls. So this really was about making sure that we would keep the voices of the girls at front and center of our response to COVID-19. So by conducting the surveys with the girls and with the mentors, we were able to understand how they were affected, and many of them reported an increase in gender-based violence in their community, an increase in insecurity, as well as an increase in economic hardship, and overall an increase in stress and anxiety. So we use that feedback, we use what the girls told us to inform the adoption of the life skills curriculum, to then integrate more focus on psychosocial well-being as presented in the presentation. Was there another question, Kate?
So thanks so much, Giulia. I think that wraps it up.
Okay.
We will continue to respond to questions in the comments section on the LinkedIn post for each video presentation. But at this point, let's pass the mic to Daniel.
Sure, thank you.
Good afternoon, good evening, wherever you are. My name is Daniel Tobón Garcia. I'm extremely passionate about working for the health and well-being of children and adolescents and young people. As you will see in the presentation, this passion is strongly connected with my personal story growing up, which briefly mentions sensitive subjects related to mental health. I really hope that you connect with my story as well as with what we're doing to support schools become safe and protective environments for well-being in children and adolescents. I really look forward to your questions and an exciting conversation afterwards. So please do use the QR code to participate. And really excited to be with you. Hi, my name is Daniel Tobón, and I want to tell you that I'm obsessed with making sure that every child and adolescent can live a healthy and happy life, especially as they go through school. I'm a medical doctor by training and the founder of Welbin, a startup that supports educational communities to understand and improve the condition for children's well-being based on evidence. In this video, I would like to recall a time in my life where I struggled with my mental health and how that led me to create the Welbin Index tool. It was 2007, and I had just gotten out of high school and enrolled in medical school. One day, I found myself laying in bed, surrounded by a surgical kit, and about to make cuts in my forearm with a new and shiny scalpel, asking myself if my life was worth living. And I understand how that Daniel of 2007 felt. I can still hear the name calling, the sounds and comments made by my peers in high school when I dared to raise my hand in class or just to go to the front to present something. At that time, I couldn't dare to speak in front of many people like I'm doing now. I didn't have the best grades, and I had very few dreams because all I had in my mind was the dream to make all of that suffering stop. Fortunately, this question came with a realization that I was not in high school anymore, and that I actually felt safe in my university environment. I literally decided to clean my hands, seek help, and find my meaning and purpose surrounded by my friends. However, the question of why my life was suffering never stopped visiting me. It visited me again in 2011 when I proposed an intervention to the UN about comprehensive child health. I mentioned Santiago, a 12-year-old adolescent who ended up in a hospital due to anorexia. He had lost 15 kilograms, around 30 pounds, in just 6 months without anyone noticing. So I kept on working with the dream to ensure that Santiago, every child and adolescent and young person, could live a healthy and happy life as they go through school. However, the problem is that we don't even know the number of schools that have access to water in the region of Latin America and the Caribbean. And if we don't have access to that information on basic services in schools like water, then what can we expect in terms of conditions and practices to promote mental health, peaceful coexistence, gender equality, among other things? This is why I created Welbin, an initiative that was born between 2019 and 2020 to support and help educational communities understand and improve the conditions for well-being in their schools, including good practices and red flags. This initiative is dedicated to all who dream of a school centered on children's well-being. Our main project has been the Welbin Index, a tool created by me and some colleagues to assess school conditions for well-being at scale. This tool is a self-assessment tool the school principals take in consultation with representatives of the school community that delivers quick reports and recommendations. It takes a whole school approach and is based on the global standards of health promoting schools. I would like to share some findings from our implementation in Colombia in 2022. These schools are located in rural and urban areas. They are public and private and serve over 1 million students from more than 350 municipalities. Over 35,000 of these students are migrants. This technology allows schools to receive their assessment in less than an hour on average, so we can reach many more schools rapidly, regardless of their location or their ability to pay. And we have found that on average, these schools meet around 50% of recommended practices to promote the health and well-being of their communities. Rural and public schools score systematically lower than private and urban schools, meaning that interventions need to be really based on the specific realities of each school. Additionally, we found that approximately 8 out of 10 schools don't feel that they're appropriately supporting the social, mental, and physical needs of their students. And this is a call for all of us to really do more and better to support those schools with practical and easy tools. However, discussing policies, environment, services, and partnerships does not sufficiently speak to the everyday needs of school communities. So we created a set of thematic indicators that address specific conditions for well-being that we know are a source of concern for many schools. Mental and emotional health, peaceful coexistence and inclusion, sexuality and gender equality, nutrition and healthy lifestyle, and physical integrity and security. While schools are doing important and great work in trying to create safe and psychosocial school environments, they have a long way to go to incorporate these practices into their official policies and guidelines, curriculum, and partnerships with other organizations and services. This is important because children do not go to school just to learn math and language. Many families take their kids to school and expect them to be safe, happy, and protected. Children should have the opportunity to socialize, dream, and acquire the needed skills to make those dreams come true. We don't achieve that with a narrow perspective in education, only measured by standardized tests. With that data from 2022 in Colombia, we saw that while the #1 priority of schools on well-being was mental health, Only 40% had trained their teachers on social and emotional skills. And only 16% of those schools had concrete mechanisms to identify mental health problems and cases and refer them for appropriate care. The same situation presented and persisted in the case of peaceful coexistence and inclusion. While 96% of participant schools had protocols to deal with violence and coexistence situations in school, only 19% had concrete mechanisms to identify cases of violence and refer them for appropriate care. And in terms of physical integrity and security, we saw that 62% of schools have formal partnerships with external actors, protection actors. This is great. However, 43% are located in areas where drugs are being sold, psychoactive substances, and only 26% are providing trainings to prevent gender-based violence. I am sure all of us hearing this can think of one child or adolescent we want to protect, to whom we want to make that promise that they will be safe and happy when they go to school. And I want all of us to think for 1 second that every day that goes by is a day that that child or adolescent that is special to you has to go to school without that explicit promise. Working to fulfill this promise is worth it. It's worth millions of lives. And although we will fail many times, making that promise will bring us closer to making it a reality. That's why I invite you to go to this QR code to say, I want healthy, safe, and protective schools. We will continue to advocate for you and hopefully partner with you to ensure all schools are centered on well-being. This is not only free, but also our shared responsibility to do. Thank you so much for being a part of this stream.
Thanks so much, Daniel. Let's check in with the Slido and see what questions have come up. So there is one. The pandemic started in the middle of your project's development and implementation. How did it change your ideas and assumptions?
For that question. Indeed, it did, the pandemic did happen in the middle of the project implementation. So it started in 2020. And immediately we were about to pilot the tool for the first time in the beginning of 2020, and the pandemic happened. School closures became the norm, and we had to quickly adapt. In the first, some colleagues were saying, oh, this is going to be temporary. Let's not change everything that we've done and move on. But really, we needed to act. Health and well-being in schools had never been so important until the pandemic, or so evident that it was important. So what we did initially was to adapt the tool to include different standards and recommended practices in that moment that were recommended to prevent COVID-19 infections in schools, to reduce the risks. And we saw it really as a mechanism to help schools prepare, cope, adapt their situations, their conditions in order to continue providing the service of education, not close down. So we adapted the tool, we made it lighter, more brief. We included different questions related to how they were addressing COVID-19 and infectious respiratory diseases. And then we piloted it virtually with different schools. And we partnered also with organizations that were really interested in Colombia at that moment to ensure that the school closures were as short as possible, because we really wanted to give schools and governments and organizations the information that they needed in order to make the necessary investments and adaptations in order to have, to bring back school operations. So that's how we adapted the Welbin Index during the pandemic. And we kept asking those questions in the first couple of years, and we maintained some of them because they're still important in order to address respiratory infections, even though the pandemic is not as prominent as it was in that moment.
Great, thank you.
That's a great question.
So there are lots of questions around the index itself in the Slido and in the chat. So for example, can the Welbin Index be used in other education projects? Has the tool been used in other countries? How have education authorities responded? And do students have access to the results of the survey?
Great questions. So initially, we've only implemented it in the first couple of years. We only implemented it in Colombia with increasing number of schools, more than 3,000 schools in Colombia, 3,500 schools have used the Welbin Index in Colombia. And last year, we began implementation in another country, in Jamaica, with 50% of the schools participating in that survey. The Welbin Index in and of itself, the application for schools is free. Every school, when they fill the report, the responsible person for doing this is a school director or principal, but we recommend that it is responded in consultation with representatives of the school community, so teachers, parents, and students. And at the end of that, when they finish filling out the survey, which takes about 45 minutes to an hour, the school immediately gets an automatic, free, and confidential report. This year, 2023, thanks to the support from USAID and Education Development Center and colleagues here, we will have the tool available in Spanish, English, French, Portuguese, and Hindi. So we hope that it will be available for different partners in other regions of the world that speak these languages. We have had very close contact with education actors, government actors, and also non-governmental and private organizations interested in promoting the health and well-being of students and school communities, because they understand the close relationship between school well-being and also school performance. But usually they do not have the information to make those decisions be as impactful and sustainable as possible. So I'm not sure if I've answered all of the questions, but it will be available for other countries, and we will have another webinar in March, or we could connect on the chat just to get that information, and we can connect with you just to see if we could partner with you to implement it in your country and your region. We usually do it in close collaboration with education communities. And about the students getting the results, initially they don't get the results. The school principal, which is responsible for the response of the questionnaire, is the one who gets the report. But apart from that, what we've done is that in different projects, we've supported schools to engage with students to analyze those results and create action plans based on evidence to ensure that they can really make progress in their conditions and practices to promote well-being.
Great, thank you for all of those responses, Daniel. Before we transition, is there anyone who wants to come off mute and ask a question?
I briefly want to touch on something that I see on the screen.
Sure.
And I think it's an important thing to clarify. The tool assesses conditions and practices for well-being at the school level. It does not look at individual conditions or situations for well-being, because what it intends to do is to show the school the issues, the conditions, and the practices that they can control, that they can change and adapt. It shows them what they're in control of to make better and more informed decisions. Of course, we want that schools to monitor the individual well-being, but that doesn't give enough information for the decision makers at the school level, including students and families, about what to do next. I usually use an example that I think it's interesting. If I'm a school principal, I'm not an expert in mental health or health promotion, and I'm told or I'm reported that the previous year 5 or 10 students committed self-harm or committed suicide, I'm really not equipped with enough information to make decisions for the next year. But if apart from getting that report on the number of students who conducted self-harm or suicide, if apart from that, I have information on the 5, 10, or 15 things I need to do to promote mental health and well-being, and I know how I am doing as a school in those indicators, those standards, then that gives me clear information on what decisions to make for the next year. And so that's what we really focus on when we look at the school conditions and practices. And we understand, we have evidence that it is strongly correlated with academic performance. So it really gives school principals and school communities the information they need to make decisions.
That's wonderful. Thanks, Daniel. There is a request in the chat for your website so that people can check out the Welbin Index in greater detail. So if I'm going to ask you if you can just pop that web address in the chat. And as with the previous presentation, we will continue the conversation on LinkedIn in the comments section. So please join us there and stay tuned for future events, as Daniel alluded to, for the Welbin Index. Yeah. So we will now transition to a breakout room activity. In the breakout rooms, we invite you to spend about 15 minutes with your colleagues. This is your opportunity to network, to react to the presentations we've just heard, to ask questions, and to offer insights into additional best practices in mental health and psychosocial support from your own context. The two guiding questions that we would like you to think about are, first, what are some practices from the presentations that you would like to learn more about? And second, what are some effective practices not mentioned in the presentations that you would like to share? Before we open the breakout rooms, please note that the link in the chat will open to the breakout room activity page that you are now seeing on your screen. You will see the activity instructions on the left-hand side and hyperlinks to each of the small group documents. As is being demonstrated, you will click on the link that corresponds with your breakout room number, which will open the slide that you are now seeing on your screen. Event organizers will be joining your groups to ensure that you have the links. So we will now share the link to the breakout room activity page in the chat, and rooms will open in just a moment. I hope you all enjoy the discussion. Welcome back, everyone. I was able to join a couple of the discussions and listen in a little bit. It sounds like there was some really great learning and some vibrant discussion going on. I hope we didn't bring you back mid-thought. It would be great to hear some of the highlights from those breakout sessions. So I can tell that there were a lot of questions about how to implement the Welbin Index. Responding to the first questions, practices from the presentations we would like to learn more about. People would like to understand how Welbin is addressing the challenge of school principals for self-reporting, and also the question of social desirability bias. We're curious about some of the ethical responsibilities of schools and teachers to help find referrals or flag a young person who they think is suffering from a mental health issue, and to talk about how programming addresses issues related to gender-based violence and specifically for adolescent girls. So that was in response to the first questions. I'd like to give Giulia and Daniel a minute to respond. And then if anyone would want to come off mute and provide reflections or other questions, we should have the opportunity to do that as well. So Giulia, Daniel, please, how would you like to respond to these first questions?
Thank you, Kate. I can go. So we do have a situation in terms of the self-reporting method. There's definitely a situation, but even though we're audacious, we do want to be practical as well. And the Welbin Index is mainly a tool for schools themselves. It's not an external evaluation or assessment or an auditing process. It is really a tool for schools to make decisions. So the report that the schools get is based on the responses that they give. So the more accurate the responses are, the report and the recommendation is going to be more accurate as well. This is not done, like I said, by an auditing firm. This is a tool that we want schools to have in their hand, in their pocket, if you will, to assess their conditions. What school principals say when they take the tool is that even when they're not getting the report, but just responding to the questionnaire, they're understanding that there are good things that they're doing. They have good practices, and it's very good for them to learn that, because we often, different organizations always focus on the negative, on the lack of. And so it's good for them to know that they're doing things right. They also realize that there's something that they're doing, but they can take it to the next level, and that they hadn't thought about that. And then they also say that they understood and realized that there were some practices that they could do, good practices, that they had never even thought of. And so it's really a tool for them. We have conducted analysis, and we understand that, and we've seen that responses do have a normal behavior. So it's not biased to one or the other. We have conducted validation techniques to the tool, which shows that the tool in itself, it's very valid. We have a Cronbach's alpha of 95%, which is really good for an index. And so really we do have that bias, of course, but at the end of the day, it's a tool and a result for them. We're going to have another webinar in March to talk more about how to implement the Welbin Index. But in the meantime, please do drop me an email. I'm putting it in the chat just to see how we can get in contact with you to go through the Welbin Index and how can we implement it in your context, and we can have all of that information for the schools. Absolutely, it's free of charge, because the main goal and purpose is to ensure that every school, regardless of where they are, regardless if they're been prioritized by projects or grants, has this in their hand, a tool to assess their conditions for well-being and start this process of making evidence-based interventions in their school settings.
Thanks so much, Danielle. I'd like to invite Giulia to comment also on the questions particularly related to ethical responsibility and to gender-based violence.
Sure, of course. I guess in relation to the question on addressing issues related to GBV, specifically for adolescent girls, in our experience, in designing the program to address these issues as a girls' education and empowerment program, the scope to do GBV prevention and response was, of course, limited. And so we had to think about the risks that we might face in doing further harm to the girls, because the mentors are not trained as GBV case management workers, or they're not equipped to provide that case management services. We don't have the resources, we didn't have the resources to hire case managers or to provide that intensive training and ongoing supervision to ensure quality case management at the community level. Also, many mentors had other responsibilities and did not have sufficient time to provide that type of support and follow-up. Also, the safe spaces do not have, minimum requirements for keeping confidential case files. And so, because EAGER is not a GBV response service on the referral pathway, and we didn't have the formal mechanisms for safely managing that, we had to think of the key steps that we could take to support the girls while keeping in mind our obligation to do not do any further harm to the girls. So one of the ways that we have done that, first of all, was to ensure we completed a service mapping exercise across the country, across the locations where we implemented the project, so that we could identify service providers who could provide health protection, legal case management, and psychosocial care for GBV survivors. And after collecting this information, we have prepared a very simple service directory in the form of a service tree, so that every mentor could have an easy to understand tool to point the girls to the appropriate services with the correct information about contacts, about accessibility, and so forth. And the mentors have been trained and have been coached on how to use this tool. So as appropriate, this directories included services to respond to GBV cases. And another way to support girls and mentors to navigate GBV instances was to train mentors on psychological first aid. So through an approach of look, listen, and link. This is framed as being a safe person for girls. So really emphasizing non-judgment, non-blaming, and using healing statements. So this is a complement to other trainings and other support that the mentors receive in life skills, and that all emphasize the guiding principles of safety, respect, confidentiality, non-discrimination, empathy, active listening, and positive body language. So by encouraging reflection on what it means to be a safe person, the mentors are also encouraged to be more aware of their own beliefs or their own attitudes and responses to GBV. And because they play such a critical role in whether the girls feel safe, they feel supported, they feel they can trust them, it's really important that the girls are not blamed, are not shamed, they're not judged or further traumatized by GBV. And so really investing resources in building the capacity of these women at the community level to be safe persons for the girls. It was one of our strategy to mitigate the many barriers of working in remote areas where girls do not have access to services and do not have access to case management, but still are, at the intersection of most of these barriers because they're further isolated, further marginalized, and so more at risk of GBV. So really trying to leverage the resources at the community level, while also shifting attitudes within the community by working with mentors. So this was one among other strategies that we implemented to support girls and mentors addressing GBV instances.
Thanks so much, Giulia. Is there anyone who would like to come off mute to ask a question or pop a question into the chat? I think we have time for one quick one.
While people think, can I just briefly say something?
Sure, of course.
Thank you. I wanted to say something about why we chose school directors. I think Janella has a question, but just briefly to say that the questions that we ask require, broad understanding of the school policies, the school community, the context, and it's not that we think that they have all of the information. That's why we recommend that this is done in consultation with representatives from the school community, but they are the ultimate decision maker, and that's why we chose them. And I wanted to touch on the ethical responsibility also of the school teachers to flag a person who is suspected from suffering. Now, there are recommendations from WHO, from UNESCO, from the Center for Disease Control, the CDC, the Center for Disease Control in the United States, it is recommended that in schools, either provided by the school or in partnership with other actors, for example, healthcare services, to conduct screening for issues like depression, anxiety, drug consumption. It is recommended that this is done in a school setting because we have more possibilities to detect and address appropriately. I'm not saying it should be the teachers necessarily, but the school is recommended to conduct or facilitate in partnership with other organizations the screening on flagging young people who are suffering or who are using drugs in order to refer them for appropriate care.
Thanks so much, Daniel, for that clarification. And Janella, you have a question. Please come off mute.
Yes, thank you. This question is about the project in Sierra Leone, and I just wanted to ask a little bit more about the Mama Queens and what was the, I guess, criteria to become a Mama Queen, and were they the ones who were trained in psychological first aid? Thank you.
Sure. The Mama Queen are not identified by the project. It's a common way in Creole to call respected women in the communities or women leaders or chiefs at the community level. So in most communities in Sierra Leone, there would be a woman in the community who is recognized as either being the most senior or the person who people can go to because she has that respect from others. And so it's just another way of saying a woman leader in the community. In some cases, they are chiefs, and the administrative structure in Sierra Leone is such that in each chiefdom, there's a paramount chief at the community level. In some cases, these chiefs are women. In other cases where the paramount chief is a man, there would still be a mommy queen who is a trusted, respected woman in the community, some sort of somebody to go to when there are issues. And so we don't identify them. They are well known in the community in the same way as the community chiefs are. And so when we started the program, they were identified by the girls themselves and by the community-based volunteers who implement the project at the community level. And so it's on that basis that they were involved in all the activities we implemented with community members.
Thank you so much. A warm thank you to both of our presenters, Danielle and Giulia, and to all of you for your active participation. I think we would like to launch a quick poll to ask you about how you might want to engage with ECCN in the future. I think you can see it on your screen, so please give a quick response. And while you're doing that, I will also remind you that there are several ways that you can engage with ECCN, including connecting on LinkedIn, where we will continue this discussion once the videos are posted using the chat function or using the comments function, excuse me, on LinkedIn. And I believe that someone will pop into the chat right there, the links to the ECCN page and the member group. So please feel free to join. So it looks like participation in the poll is complete, or as complete as it's going to get. We'll just close in a second. Wonderful. And we will also be sharing the results with you. I believe you can see on your screen the distribution of responses, that it looks like the majority of you are interested in learning emerging good practices. and gaining access to practical tools as well as ways to collaborate in the future. So this is really helpful for us in deciding how we will formulate events in the future. Before we close, I wanted to alert you to some future network events and hope that you will stay tuned for them. On February 28th and March 7th, both at 10 a.m., the Higher Education Learning Network will be exploring inclusive access to higher education in a series of events. They will also hold a member networking series on March 21st. Again, that's with Helen, the Higher Education Learning Network. And we do plan in March to have a cross-cutting event on financing disability inclusive education. Following today's webinar, as I said, we will be posting the pre-recorded videos that we watched today on ECCN's LinkedIn page. Please join us there to continue the conversation asynchronously. And finally, I want to thank you all for your inputs today, which will certainly influence our network's future directions. And I am looking forward to advancing all of our work together around mental health and psychosocial support through ECCN. Please remember to join if you aren't yet a member. The link for our new sign-up form is in the chat box and the QR code at the top of the slide. Thank you very, very much, and I wish you a wonderful conclusion of your day and week.